So the question was, when can you work on a scar? How soon after the creation of the wound can you work on it? So, there's 3 phases of healing. There's the clotting of the blood, and then there's the acute phase, the subacute phase, and the remodeling phase. During the acute phase, the tissue closes up. During the subacute phase, it starts to firm up, solidify, strengthen. And then during the remodeling phase, some of the initial scar material, collagen and elastin type material, is reabsorbed and replaced, and the fiber directions changes and that sort of thing. You don't mess with something that is in the acute phase, period. You can work around it. You can massage everything else, but just leave the area alone.
If I have any thought, is sometimes at distance to approximate the tissue towards the wound to help support that healing. But that's not by it, but just let's say the wound is, knee replacement. When I'm working here, maybe there's the lymph, the superficial lymph stuff, but deeper, maybe some approximation towards it if I'm thinking about facility, but
push the ends together if you're going to do anything. But mostly just leave it alone. And the acute phase can, depending on the person, can last up to 7 days. It can be shorter than that, but that gives you a good gauge. You want the wound closed. You don't want it fragile. It can still be red. It can still have some coloring to it. But what you do to it is you still approximate. And then when it starts to get further into the subacute phase, then you can start to move the tissues back and forth. And that's when you could put a light suction cup on either side of it, not on it. And then you can pull them together and pull them apart, move it back and forth, which encourages a mobile scar development. But you're a month in on this. And the biggest concern is, especially in the acute phase, is that you don't want any infection. And so better
leave it alone.
Better to just leave it alone.
When there's any kind of open wound.
And into that subacute phase. So it doesn't mean you can't give them a massage. You can, if there's some swelling around it, you can maybe try to get the fluid to move a little bit. But just, I tell people, stay a thumb's width away from the thing. Don't put any lotion around it, Now there's a trend in lymphatic work to push fluid out of the wound. Don't do that. That's not good, especially if you're looking at a wound that has to do with any kind of joint replacement or placement of a prosthesis or something, like if they had a chin implant for plastic surgery or something, because bacteria likes to collect around those things. And infection is just a nightmare when you get it around that kind of stuff. Once it's in the remodeling phase, 6 weeks to 2 months to 3 months out, and it's starting to turn white, the scar tissue is starting to turn white. If it is stiff, and it's limiting range of motion, then you can get closer and closer and closer with the cupping. Most of the time, what we are going to deal with is old scars. And you can put cups on those, and lift them and move them around. And there's typically a sense of a burn, a lift and a burn sensation, and you only do that till it's warm, then you stop. And I usually teach people to do that themselves.
Warm to the touch.
Warm to the touch. I teach them to cup it or scrape it or I used to have to teach them to yank it and pull it, you know, lift it up and move it back and forth, but now it's easier with the cup.
I tend to default to that 3 month as the beginning,
Yeah.
feeling pretty safe with it. And then it depends on the person's adaptive capacity, age, all that kind of stuff, how well it progressed. Through physical therapy and everybody said there's nothing no more to worry about, etc. But beyond that 3 months to 6 month, 6 month is where I feel pretty secure, as long as the things have tracked relatively well.
Yeah, and but these trends that are out there with some of the lymphatic drain stuff are frightening.
It's not anything to do with just the construct of fighting inflammation as this ultimate demon, right? I don't need it to chiming in too much, and I'm only parroting her really with this. But it's recognizing that in the acute phase of injury repair, inflammation is the healing process.
Yep.
So the idea that we build these terms like inflammation and toxins into like these bigger umbrella constructs that then are treated as to be always fought and always worked against, in those acute phases recognize that the inflammation is doing its job and we should support it doing its job and not fight against it. That includes even the recommendations to not take anti-inflammatories. Too many anti-inflammatories, something more like a Tylenol, because then it's just mitigating the symptom, not actually shifting the process of healing. We have to think the same way in those acute phases. If it's chronic,
That's different.
right? But there's this underlying demonization that has kind of, and I think it just gets easier for everybody to start falling into that. And then you get these trends of, didn't matter what it was cases even when we were working with stuff of like the initial phase with like injury was always to just wrap the living daylights out of it and like compress it. And that would work for a time on somebody that's pretty young, but ultimately, you know,
Everything gets wadded together.
there's limitations. It's just like why they want to, now there's been lessons learned where they don't cast stuff as much, right? Because then things don't heal. They were healing less mobile. But, man.
Well, and the same with things like the back surgeries and that sort of thing. I'm not afraid of working on scars. In the abdominal area, that's where you get the real difficult adhesion problem, is abdominal stuff. And they're doing most of that through these holes. They poke 3 or 4 holes and stick stuff in there and blow you up with
That's how you get
hair
appendix.
fluid and ram around in there and stuff. Now, those tissues, they're mucousy in there and they're a little sticky in there and they will stick to each other. That's a true adhesion. We don't break up adhesions. We maybe get things to slide a little better. There is some research that shows that if you mobilize the abdomen right away after a surgery, now you don't have to be specific, you just mobilize the area, that you can reduce the development of these internal abdominal adhesions, which are problematic. But that's not where, that should be a nurse that does that. You know, massage is in a nursing, that's a therapeutic intervention. You know, a real surgery is dangerous, it's chronic, you know. You don't have enough training. I don't have enough training to get into all that. You know, when you gotta worry about infection control and adverse effects and, you know, all that kind of stuff. I don't think that's where we shine. And the lymphatic stuff is starting to try to move into that direction. I think somebody's gonna get sued.
There are a lot of surgery centers who like recommend that their clients get lymphatic.
Yeah, but they don't know what they're talking about.
Right. Well, and then the client gets frustrated with you because they were told it's okay.
Yeah, and you can generally support fluid movement in the whole body. We've got a protocol that we made up, all based on evidence-informed kinds of things, that would support fluid movement everywhere. But to try to squeeze fluid out of the wound and some of the stuff that they're doing now, I mean, as far as potential for danger, if you're using just the light skin drag methods, that's pretty safe. But they don't know what it is. The client doesn't know what it is. most of the massage therapists don't know what it is. We've actually got a really good YouTube video on it. And so, but these are the kinds of things that occur that give us a reputation of not knowing our lane. And then that doesn't speak well for networking and that sort of thing. So if somebody comes in, they don't know what lymphatic drain is either. Have you had it where people come in and said, I want you to do lymphatic drain?
They've called.
Yeah. And what we just say is we do general lymphatic support. That's what we do. So actually, one of the things that'll move lymph really, really well is a whole body vibration plate. That's good research on that. Second to that is appropriately applied elastic kinesiology type tape. Because what it does is it lifts the skin and superficial fascia, but you don't put it on the area. You put it on either side of it or above and below it.
The other one, though it's harder, sometimes sanitation-wise, depends on the nature of the wound, is a water immersion. So the hydrostatic pressure.
Yeah,
But
after the wound's closed.
yeah, and there's about as safe as you can get.
You know, so there's, nobody gets to go to physical therapy forever, right? That's just not the way the insurance works. Let them go and do their physical therapy. They're going to get discharged from that. There's still going to be problems. They got a new normal. They're not going to be normal again, the way they were before. That's where we come in. We take care of the rest of it. So I don't ever discourage anybody from doing a course of physical therapy on something. And so that's usually 2 or 3 times a week for maybe 6 weeks, and by that time everything's healed and we're ready to go. That's a very good question, but it's not going to hurt either. As long as you follow that, don't get all caught up. If that's with anything, don't get all caught up with something where you could re-injure the tissue or move it beyond its new limits, or they're not doing a whole lot of back surgeries anymore where you get the big old scars along through there. But they are doing some what they call Band-Aid surgeries, and sometimes they're needed. My daughter had a L4 nerve compression. It truly was a stenosis. It truly was a narrowing of what was going on. The nerve was truly pinched. And she got 80% relief by them going in there and mechanically reaming that hole out so that the nerve has got more room. We couldn't do that. She could get a massage, we could work around the area, we could do things that were compensating. She'd feel better for a day. So we want to, again, we're coming out of a time where massage therapists felt like they could do everything. And you'd never want to go to the doctor. They're whatever. We're out of that now. That's not what it is. It's more about understanding and networking and integration and consultation and that sort of thing. And that's working really good. You just gotta, you don't have to work right with them. Referral back and forth is fine. It's just, developing the relationship and the trust that goes with it. So, any other questions that came out of that? That was good.
I actually have one.
Yes.
What about after like a car accident or a slip and fall where there is no open wound and they don't have any breaks or tears or strains?
You don't have to worry about the infection.
Right.
All right.
How long after that?
I still will superimpose the acute phase.
Okay.
So somebody will say, I got in a car, I'm fine, I got a little whiplash. I don't believe it.
I'll still wait like it.
And typically after you've had something like that happen, you're going to be okay because you're in shock. And then you're going to be, the next 24 hours, you're going to be really stiff and sore, and you should be, because everything wants to hold things still. And then the next day you're going to be worse after that. And then it should start to slowly resolve after that over a week to 10 days. Now, if it doesn't, then there's something more serious than a soft tissue. With this kind of a jarring, you get little micro tears. So stuff goes,
Think like a freight blanket.
yeah, it goes whop, and then it goes whop. This is where the injury is that. Unless it whopped onto a bone, then you can get a bruise, a bone bruise in there. And Luke mentioned taking anti-inflammatory medication like Aleve or
Any of your ibuprofen.
aspirin, ibuprofen, that sort of thing. You're interfering with the inflammatory response. So now there's this big thing out there where don't put ice on it. Have anybody heard that? Don't put ice on stuff. Typically, ice isn't going to penetrate deep enough unless it's maybe around the ankle or the wrist to interfere with a normal inflammatory healing response. But just to be if you just want to be careful about not putting ice on an acute injury, wait a couple of days. Better to put ice on something for pain control than to take a pain medication. And ice works better for pain control than heat. But you can alternate hot and cold, or you can put hot on it. Not the first 24 hours, because you just let the acute inflammation do its work. For chronic pain, ice is great. And it numbs the nervous system. And then once you take the ice off, it's got to warm up, so you get a secondary blood flow response to it. But a lot of people don't like ice. So if you're looking at hydrotherapy, which is one of our things to talk about a little bit today, is start out with warm, and then put cold, and then warm, but you finish with cold. So I use ice all the time, and it's a great counter irritant, and you get some actual analgesic action with it too, because it stimulates those cold receptors. And so I think things like that could augment what we're doing with the massage or something like that. So they're also talking about things like red light therapy and all kinds of stuff. I mean, there's all kinds of stuff out there. All right.
In terms of when, there's kind of, you're hearing like the rules of threes. Like it's something pretty mild, like an almost fall, kind of 3-ish days. Something maybe a little bit more than that, 3-ish weeks. Something big, 3-ish months.
Gotcha.
That's really good, Luke.
Wow. Wonder where I got it from. Probably.
So what was it?
There's something mild, 3-ish days, something moderate, 3-ish weeks, something big, and 3-ish months.
I did that. I bet you I learned that from somebody.
Maybe it was me.
I'm amazed by my own self.
Just reciprocal learning and forgetting.
Okay, this last little set of visuals I have here are just giving you a sense of perception on some target areas we're going to work with. So these are my fly glasses. All right. Okay, so in this one, we've got, let's see if I can do that for you. We're looking at the scalp area, and what I want to bring to your attention, an area that is not worked on as much as it could be to get results, whether it's a headache or a stiff neck or whatever, is this tissue right here at the occipital base up until the mid part of the skull. You want to really get in there and allow for some compression and stuff in there.
You'll learn that as either the occipitals or occipitofrontalis, which would then share with the eyebrow muscles. So,
Right through here. And then the other thing is, this is where that sternocleidomastoid comes in. That up and through there. Now that position that I had you in down there, that gets all of that.
Yeah, that's great.
You know, and all I have to do is move, whoops. All I have to do is move up over the occipital protuberance right here and into this part of the scalp. So if you feel, start right where the top of your ears are at and draw a straight line across, make sure that you're massaging below that line on the scalp. And then probably what you're not doing is adding movement with it. So movement that you can use if you got the head all pinned down, believe it or not, is you can move the eyes. So press into those muscles right above your ears and down the side of that scalp right there. Good firm pressure in there. Now roll your eyes in a big circle. You'll feel those muscles move under your eyes, or under your hands. Feel it? So that's one of my little things to do in that area is roll your eyes in a big circle. And you get that idea of contract, relax, antagonist, contract, contract, relax, antagonist, contract with it. 'Cause you can't really stretch those.
all of those up until even temporalis, certainly masseter as well, but I've had greater effects thinking temporalis, occipitofrontalis for TMJ and jaw stuff.
Yeah, if you're thinking about TMJ stuff, you want the muscles in the front, the muscles in the side, because people work on the masseter. And that's part of it, you know, but a lot of that is coming from connective tissue pulling in through there. So if somebody asks me to work on their TMJ, I just work on everything. And then I'll check, do a drag palpation along the side of your face, along your jaw. I actually have a little sticky spot right there. And I can check and make sure I'm on the masseter, because with my mouth running like this, I feel it pop up. And so I found a sticky spot. I can press into it. Not really familiar. Could have been where my glasses were at. I'll run it again. There's one right there. Oh, yep. And I did. I woke up the other day. I must have had my mouth locked open. Who knows what I did with it. But I can press right in there, and then I can go, is there a way I can move that so it's less sensation? There. That's ease. That's a technique right there.
Any of these spots, so especially
Yeah.
masseter and temporalis, will be most closely associated with actual jaw actions. So not just open and close, but the shearing back and forth, and forward and backward.
Yeah. And then
Coaching
I
a
can-
person to play with each one of those actions and see which one then gets the ease.
And then I can find where it hurts the most, or where the sensation is the strongest. There. Now that's direct. Indirect, take it to ease. Direct, take it to bind.
Strain,
then-
counter strain.
Check and see if it's better. You can, that is the sequence for everything. Same sequence.
And coaching your clients to be a participant could get them a clue as to what we're talking about, because it could be they move their ears or their pinky fingers or their pinky toes. I don't care. Whatever they do that achieves that position of ease is assessment for me, but then they're going to give you clearer information than you just guessing. And then they can then shifting to a more direct concept that I'll say, now move in the opposite direction, find something that stresses it and challenges it. Not too far, but find something where you're kind of pushing it to the threshold of tolerance, and then we'll back out to the ease position. Yeah.
And, you know, a lot of people suffer from TMJ, but you can use the same thing in a shoulder. You can do the same thing with a frontal-based headache, you know. I dealt with a ton of those with the athletes because the helmet would ride on there and they'd squint in the sun. You know, so this is a structure called the nuchal ligament. I want you to get an appreciation of how much depth it's got to it. All of the muscles in the cervical area and up into the scalp up here attach into that thing. So it's like what's called a raphe. And once you get a connective tissue separation that runs it runs up and down, or in some instances back and forth across, and a lot of stuff attaches on it, if you can bend that stuff back and forth. So when you're massaging the neck,
Bring that to the camera. But really the depth of this is quite profound, because if you look at how much, you know, that's right there to my middle knuckles, right?
right at the base of the skull.
So that ligament comes out like a little fin right in here, all the way down onto C7. So I mean, but when you look at a person standing sideways, that's so flush, and then this is packed, but just we'll think about the muscles and not think about this crazy dolphin fin you have hanging out there. And it can be bending that fin back and forth, affects
All of it.
all of it. Did you still want this here?
No. So put your hand right there like that. There is the nuchal ligament. There's millions of things all the way around it. My technique is to come in and bend that back and forth. And maybe move the head up and down, because that's going to pull on it. So technique-wise, Renee, I'm going to come touch you.
Yeah.
Technique-wise, and it works best sideline, technique-wise, I'm going to just grab in here and move this back and forth across here. Not up and down, you know, back and forth. And then that's going to get all of everything that attaches in through there.
Sometimes supine it works, but sideline is always going to be better. A person's laying on their side. I'm setting up where I can just come over, reach, and pull. I'm using this sloth claw here, back and forth. Either hand. Supine potentially same orientation, but then you're just going to get stuck more on kind of an odd angle. The more of all of that you can grab and move back and forth, the better. So that tends to be the best, because I can hold here, come over, and then depending on how much of a neck the person actually has, that can be the only distinguishing factor that can mess you up a little bit.
Yeah, I've had people that have no neck.
and then they are harder to work on.
All right, so next picture here is going to show you the depth. So this line right through here that I've got, that's that nuchal ligament. And that all of this nonsense is attaching back there. And they're primarily neck extensors and rotators is what they do. But we don't walk around with our neck extended all the time. So that means that their primary function is stabilization and support. And when you've got something that's stabilization and support, the motor tone increases so that it just doesn't have very much range of motion to it. So just moving it back and forth across the grain and some of the pressure stuff that we showed you that changes the shape. You know, I think a lot of people hurt their fingers trying to work on this. You know, they're got them on their back and their fingers are underneath and they're up and they're pulling, and I'm just not going to do that. Okay, So here's another aha of that. This again shows you how these muscles are layering up in through there, and the importance of working right along that line above your ears. This gives you a posterior view of that and starts to get you into the idea of the suboccipitals, which you can't touch. You can press on something that presses on something that presses on something. So you press as comfortably and as far down as you can, and then you need to have them do some movement so that they're massaging from the inside out. This also shows you that sternocleidomastoid as it comes up and the levator scapula. This is another orientation of those deep suboccipital muscles. Now that's the source of a lot of headache. They're really about checking the forward movement of the head, and they work with the vestibular response to maintain your balance.
Meaning, with especially these deeper structures, eye movements also is a way to engage them on and
Yeah,
off.
same
On
thing.
and off.
Pressure with movement. This is just another, the sternocleidomastoid muscle is huge. And you can get pressure on the attachment just behind your ear. A lot of times what people want to do, and there's nothing wrong with that, they'll want to grab a hold of it directly and get a hold of it. You can do that, but that's uncomfortable. It gets the gag reflex. You have to be careful with stuff in the anterior portion of the neck. So try getting it up here at the attachments first. And then once you get a pin, you can do that. Just get your hand cupped up under your ear, base of your skull, pin. Now, the movements are tip the chin, turn the head, and take a deep breath. When you take a deep breath, you should feel something tug, just like we did with the paper towel. This is another orientation of that monster. Then we have the scalenes.
Can you go back one slide? Okay, good.
Ta-da! Scalenes don't attach to the skull. They're vertebrae and rib. So they work a little bit for stabilization. But what they mostly do is lift the first and second rib for breathing, which we're not supposed to do a lot of. So when we do upper chest breathe, which we all do a lot, you can tell. Go ahead and put your hand on your chest, right above your, that's right. And then take a deep breath. If you feel your hand move, you're upper chest breathing. So that means you're using auxiliary breathing muscles to lift your ribs. And so that's not what they're made for. They can do it, but that's not what they're made for. They're more of a stabilization unit in through there. And the brachial plexus runs through that. So when they shorten and pull up, then they start to press on the brachial plexus, and then you get radiating pain, either up into the head or down into the chest or behind that terrible spot that's behind the shoulder blade. A lot of that's coming from that area.
When those are meant to engage is during sympathetic arousal.
Yeah.
When you're at like a higher cardiovascular output. But then that signal's supposed to shift off. Thus the correlation between interfacing with upper chest breathing muscles and dealing with like stress, anxiety. So
this is an anterior view of that. Now this is part of that strap stuff that is this one continuation of one muscle layer on top of another. It starts at the base, not the base of your skull, up here where the occipital protuberance is at, right through here at the ear level. There's this big long strap of overlapping layers that goes all the way down into your sacrum. That's where people want the pressure. And you got to be a little cautious when you get up above the shoulder into the cervical area with that. because you're getting closer to more vulnerable structures like the carotid arteries and that sort of thing. You always want to stay behind the sternocleidomastoid. So this is a decent picture of some of the intrinsic stuff without the limbs attached in here, but this is here to show you the connective tissue, duct tape, tarp attachments from the scalp, from the skull, all the way down to the coccyx. And the importance of the lumbar dorsal fascia here, and how all of this works together to support the trunk. This gives you a visual on that your low back starts at your belly button. Now there's another raphe that you have. We talked about the nuchal ligament. You've got another one, that's the linea alba, that runs right down through the abdominal muscles. And then you've got this thing on the side. So all the muscles in the back zip into all the muscles in the front at your side. And that's where a lot of people will say they want to work on quadratus lumborum. And quadratus lumborum attaches onto the ribs and the hip. It's a stabilizer. And it's not supposed to move a lot. But I will tell you, if it has been jarred or it gets a spasm in there, or it feels like it needs to protect, it's very painful. You ready to give them a show? Or,
I can't. I didn't mean to jump in.
yeah. So let me look and see what my next slide is.
This model just shows a little bit all these structures, but just dissected down pretty well, right? So base of the skull, there's your suboccipitals. We have to imagine the skull has had a mild fracture. And massage too aggressively that deep tissue only cause an injury. So the nuchal ligament would be here. So it lines up with the spinous processes, obviously, right? So right along that midline, and then everything is kind of bisected on either side. And down here you'd have these little multifidi, but here's the example of the erector spinae, and that would have sections that run all the way up the spine, with the cervical spine having some extra structures like splena cervicis, splena capitis. But if you look, we have to imagine this quadratus lumborum also over here. Okay, so we have the erector spinae, psoas, and quadratus lumborum right here, all making pretty close approximate contact to each other. So the connective tissue anchor site here is one big mesh, and it's stronger for that, sharing a place where it innervates, as well as the abdominal muscles. You see that more in kind of these structures where you'll see in your charts and stuff, how the abdominal muscles come all the way over into the lumbar dorsal fascia. But even the lumbar dorsal fascia is part of this unit, how you think going deep, just like here, going deep, we have this just seam where everything anchors into. And if you can make that seam pliable, then all those structures are more pliable. If we make this ligament more pliable, make all the structures attached to it more pliable. Linea alba, etc., blah, blah, blah.
So this is another example of the raphe there and how that stuff comes in, and then we'll deal with this more in the other two classes, but at the lumbar dorsal fascia, right? So the lumbar dorsal fascia is the big V in your low back, and then you've got this lateral raphe, then you've got your linea alba right here. You got muscles in between those things. These are twisters too. Remember I talked to you about transverse plane stuff? So you can't stretch them very well. So all of that stuff that is here on the side, you're not going to get much of a stretch on it. And so you see people trying to do they cross one leg over and then they do this and they reach their arm way up and all that. But if you put pressure into it, change the shape, that's like stretching it. And this is where the relationship of your shoulders and your hips, becomes part of the gait response. But right here in the middle, that's where forces are transferred and where you get that shearing, that twisting. So there is a picture of the magnificent psoas that functions as a hip flexor, but also a lumbar spinal stabilizer. And then there's that wonderful little latissimus or quadratus lumborum floating around in there. This figure gives you the layers again. So sometimes people will say, well, I'm going to work on the quadratus lumborum, and I go, well, I'm going to work on it too, but not really. You know, this is where you got to get real about what you can actually touch and what you can't. And then this is those strap muscles coming up where people need the more pressure, and then those are adjacent to the spinous process, or the transverse process. And then between the spinous process and the transverse process, you have these little connectors that go from vertebrae to vertebrae. Those are the ones that get affected when you have a spinal adjustment. But I'm going to show you something that you can do for that in there. So if we look at this, this is going to sum all this up, and then we're going to demonstrate some of these methods, and then you're going to work on each other. You're going to practice on each other. Massage the entire area, back, sides, and front. Spend more time on the sides and front and position the client efficiently. Remember how many structures attach into the scalp. Realize you have to go through surface tissues of the region before you can access intrinsic muscles. Most of the stiffness in the back is fascial related. The area along the spine is where people want more pressure. Change the shape of the rib cage. Address the lumbar and abdominal region as a whole unit. Support efficient breathing to achieve most outcomes. Use specific releases only when necessary. And the ones that we'll talk about are suboccipital, scalene, sternocleidomastoid, quadratus lumborum, and maybe psoas. We'll get to that in the leg for sure. Limit focused trigger point work to the ones that activate the most common symptom for them. And then support regular care, gentle exercise, balance and stability, and moderate flexibility. And that's where Luke mentioned people got to exercise some of this stuff too. We're built to walk. We do, that's frontal plane, transverse plane, and sagittal plane movement, walking. Challenges all of that. It's one of the best exercises you can get somebody to do. So, and it doesn't have to be 25 miles. All right, you ready to see some technique? All right, and then, where'd Luke go?
Back there.
Oh. All right. Let's look at how to get most pressure on the erector spinae, because that is what seems to be an area where massage therapists struggle.